Hello everyone, myself Dr. Parth, and today I'm going to teach you about the pathogenesis and morphology of hypertension. First of all, sorry I couldn't able to post the video since many days, but let's begin with one of the important topic from the cardiovascular system, that is the pathogenesis and morphology of hypertension. The hypertension can affect your multiple systems, particularly it can affect your heart, blood vessels, brain, right? So it's very important topic. So what is the learning objective for the today's discussion? So first we will see how the blood pressure is regulated in our body. Then we will look for the etiopathogenesis of hypertension, then pathophysiology and morphology. And finally, we will see the consequences, means complication of hypertension. If it is uncontrolled for a long time, then which are the consequences that we will discuss. So first question arise in our mind is why normal blood pressure need to be maintained? Why we need to maintain the normal blood pressure? So, the systemic as well as local tissue blood pressure must be maintained within a narrow reference range, that is 120 by 80 ideal blood pressure range that should be maintained to prevent the untoward complications or consequences of hypertension. We want to prevent the complications of hypertension, particularly we want to avoid ischemic heart disease, we want to avoid atherosclerosis, we want to avoid the brain stroke. For that blood pressure need to be maintained within the range. If our blood pressure is low, hypotension, then the organ will be under perfused. There will be inadequate organ perfusions in spleen, in lung, kidney, like that of organs, brain. The perfusion is inadequate, and that can lead to organ dysfunction, multi-organ dysfunction, and death. So less perfusion is also hazardous. Today we are going to discuss about the hypertension, which can especially lead to end organ damage in the form of retina damage, nephropathy, uh, left ventricular hypertrophy, and it can importantly one of the important risk factor for atherosclerosis. Atherosclerosis means thickening of artery because of tunica intima thickening, right? The thickening is because of chronic inflammation induced by hypertension. Hypertension will lead to endothelial injury, and that will lead to chronic inflammation. So atherosclerosis is a response to chronic inflammation by endothelial injury, that is ultimately by hypertension. So that's why blood pressure need to be maintained within the reference range. It is written in a Robbins book that although the molecular pathway that regulate the normal blood pressure are reasonably well understood, right? We know that renin-angiotensin system importantly regulate the blood pressure. So many pathways are understood, but still the exact cause of hypertension in most of the individual remain largely unknown. So which are the types and etiology of hypertension? This is a table from the Robbins book of pathology. See, here you can see that 90 to 95% hypertensive cases are essential, means they run in the family. The exact cause is not known. But in 5% case, you can find underlying cause that is known as a secondary hypertension, in which in this 5% case, you can have an underlying cause. That is only 5%, but in 90 to 95%, it is essential. It runs in a family. Exact etiology is not known. Particularly, it may be mediated by genetically, right? So which are the secondary causes of hypertension? The important one is renin. Important one is, sorry, renal causes, right? The renal causes in the form of glomerulonephritis. We know that in glomerulonephritis, the patient is having hypertension, hematuria, oliguria, and edema. Chronic renal disease, polycystic disease, renal artery stenosis, important cause, renal vasculitis, renal producing tumors, renin producing tumors, right? So these are the underlying etiology, renal etiology for producing secondary hypertension. We know that we will discuss later on how renal artery stenosis and vasculitis lead to hypertension, right? To how renin producing tumor lead to hypertension. Second important cause is endocrinal causes, particularly adrenocortical hyperfunction, particularly Cushing syndrome, in which we have an excessive amount of steroid production. Hyperaldosteronism, right? Congenital adrenal hyperplasia, in which there is an excessive secretion of mineralocorticoid. We know that mineralocorticoid secreted from an adrenal gland, which is located over the kidney. So if you have an adrenal gland hyperfunction, you have an excessive mineralocorticoid production, and that will ultimately lead to excessive aldosterone production and hypertension. We will see how excessive aldosterone lead to hypertension in individual. That we'll discuss it later on in the slide. Glucocorticoid, estrogen, sympathomimetic foods, sympathomimetic drugs also can lead to hypertension. The exact pathogenesis we will discuss later on in the slide. Pheochromocytoma. pheochromocytoma is a adrenal medulla tumor. So if you have a tumor in the adrenal medulla, then you have excessive secretion of adrenaline, noradrenaline, and that will ultimately lead to beta one action over the heart, and they are the sympathomimetics, so will lead to hypertension. Acromegaly, in which you have a insulin resistance, because of which there is a hyperinsulinemia, and hyperinsulinemia will increase the sodium reabsorption, and we know that whenever sodium increase in your blood, there will be increase in a blood volume, and that will lead to hypertension. Hypermetabolic state, particularly thyrotoxicosis, and in a pregnancy, particularly preeclampsia cases, hypermetabolic state can lead to hypertension. Underlying cardiovascular cause are the increased intravascular blood volume, increased cardiac output, rigidity of aorta that can contribute in a hypertension. And obviously, psychogenic neurological causes, last but not the least, they are the important contributors in the hypertension. In a chronic stress, there could be release of catecholamines which can lead to hypertension. So these are the secondary causes: renal cause, endocrinal cause, cardiovascular, and neurological. Now, to understand the pathogenesis, how this particular etiology or essential hypertension lead to organ damage, how hypertension, how there will be hypertension in particular individual, what is the exact mechanism, that can be understandable only if you know the normal blood pressure regulation. So normal blood pressure, our blood pressure is maintained by two important things. One is cardiac output and another one is arterial resistance. Peripheral arterial and venular or artery resistance, right? Peripheral vascular resistance. So these two factors maintain the blood pressure. Now, whenever the stroke volume of the heart is increased cardiac output because of any cause. For example, contractility increased because of increased sodium in a blood, right? Increased sodium reabsorption from a kidney, which will ultimately lead to increased blood volume. Excessive mineralocorticoid secretion, particularly we have discussed that adrenal hyperplasia, right? Cushing syndrome, adrenal tumors that can lead to excessive mineralocorticoid secretion. So increased blood volume, excessive mineralocorticoid that can increase the cardiac output and so increase in the blood pressure. If you have a peripheral vascular resistance, then there is also chances of hypertension, increased blood pressure. So which are the factors? Local factors are hypoxia, less oxygen supply can lead to resistance, sometime in a autoregulation mechanism. Particularly constrictors. Which are the constrictors? Catecholamines, which is secreted from adrenal medulla. So if you have adrenal medulla tumor pheochromocytoma, excessive catecholamines that can lead to peripheral vascular resistance, increased resistance. So there will be increased blood pressure. Thromboxane, leukotriene, endothelin, angiotensin 2, they are the agonist for the peripheral vascular resistance. Alpha adrenergic constricted substances that can also lead to increased resistance and hypertension, right? But when the resistance is decreased, so that will reduce your blood pressure. So the protective against the blood pressure are prostaglandins, nitric oxide, kinines. You know that all are the vasodilators. They will reduces the resistance because they are the dilators. Beta adrenergic dilators, they can also the reduce peripheral resistance, and so your blood pressure is reduced, right? The important regulator for the blood pressure maintenance is your renin angiotensin system. This is very important for understanding the pathogenesis. See, whenever you have a reduced blood pressure, the glomerular blood flow to the kidney is decreased, right? Whenever the kidney blood flow is decreased because of low blood pressure, because of that, the hypoxia is sensed by the kidney because of less blood flow, and so the juxtaglomerular cell of the kidney will secrete a renin. We know that renin will lead to production of angiotensin from the liver. This angiotensin will be converted to the angiotensin 1 by the renin. This angiotensin 1 in a lung by the enzyme, angiotensin converting enzyme, which is formally known as a ACE, will convert the angiotensin 1 into angiotensin 2. Angiotensin 2 will stimulate the adrenal gland for the production of aldosterone, and we know that aldosterone ultimately lead to excessive reabsorption of sodium from the kidney. Because of that, the sodium level in the blood is increased. They will lead to excessive water retention because of sodium reabsorption, and sodium and water retention by aldosterone will lead to increased blood volume, so increased contractility, stroke volume of a heart, and that will lead to increased blood pressure. So now you can understand that if in your body there is a renal tumor which will secrete the renin, you have a high blood pressure. If you have an adrenal gland tumor, then there is an excessive production of aldosterone which will lead to increased blood pressure. If you have a congestive cardiac failure and less blood supply to the kidney, then ultimately you have a excessive blood pressure, right? So this is the main pathogenesis behind the excessive blood pressure. Normally in our body, the blood pressure is maintained by the vasodilator. If you have an increased blood pressure, the arterial natriuretic peptides, nitric oxide, all that will be secreted, which will lead to vasodilatation, and so they will reduce the vascular resistance, and so your blood pressure will be decreased. But this compensatory mechanism fail when you have a constant trigger for the high blood pressure. Excessive sodium intake also can lead to increased blood pressure, right? So renin-angiotensin system is the main one behind the pathogenesis of hypertension. We know that sodium reabsorption increase in a Gitelman syndrome, Bartter syndrome, Liddle syndrome. In that, sodium reabsorption is increased. The individual with hyperaldosteronism will have a high blood pressure. If you have a renal failure, then sodium excretion is impaired. So there will be excessive reabsorption of sodium, which will ultimately lead to increased blood volume and high blood pressure. Excessive dietary sodium intake obviously will lead to high blood pressure because of excessive reabsorption. You are taking a more sodium, so more reabsorption and more blood volume will be increased. So the pathogenesis behind the hypertension is the excessive action of aldosterone or excessive sodium in your blood, right? So the key event is a sodium excretion. Failure of sodium excretion from your kidney will lead to hypertension. And that's why, the first line drug in treating the hypertension is angiotensin receptor blocker or angiotensin converting enzyme inhibitor drugs like that of telmisartan and enalapril respectively. Telmisartan will lead to angiotensin receptor blocker. So there is a less aldosterone, so less sodium reabsorption, less blood volume, and less blood pressure. So that is the first line drug. The another drug that is used is amlodipine, which will lead to vasodilatation. Calcium channel blocker, which will lead to vasodilatation. So they will reduce the vascular resistance and reduces the blood pressure. So that's why, if you know the pathogenesis, you can understand the pharmacological drug mechanism as well. So 90 to 95% the pathogenesis is not known, idiopathic, essential, right? But we can ultimately have a conclusion that blood pressure is a function of cardiac output and peripheral vascular resistance. So if they are affected, then you have a chances of developing hypertension. If you have a more cardiac output, more chance of hypertension. If you have a more peripheral vascular resistance, then you have a chances of hypertension, right? So the pathogenesis of essential hypertension, that is idiopathic, right? In 90 to 95%, the cause is not known. So that is very complex and multifactorial. The specific trigger is not known in that individual. But at the nutshell, we know that key feature is the reduced renal sodium excretion. So if you have a less sodium excretion in your urine, there will be more sodium reabsorption in a kidney, which will ultimately attract the water. So increased blood volume, increased fluid volume will lead to increased cardiac output, increased peripheral vasoconstriction, and that will lead to increased blood pressure. So the key event is reduced renal sodium excretion. If you have a vascular resistance, particularly by atherosclerosis development, lipid deposition, vasoconstrictor stimuli, so hypoxia, that will lead to more peripheral vascular resistance and more hypertension. So structural change in vessel wall obviously will affect your blood pressure. You know, uh, in essential hypertension, it is believed that genetic and environmental factor is the key event for hypertension development. If you have a genetic defect in the enzymes that are involved in a aldosterone metabolism, if you have a genetic defect in an enzyme that is involved in a sodium reabsorption, that is involved in a smooth muscle cell growth, then obviously you will have a hypertension. Because if you have a defect in the enzyme of sodium reabsorption, then you will have a more sodium reabsorption in your blood and the blood volume will increase, which will lead to hypertension. If you have a defect in an enzyme that is involved in aldosterone metabolism, then you have a more aldosterone in your blood, and more aldosterone will lead to more sodium reabsorption, so increased blood volume and hypertension. If you have a smooth muscle cell growth, then there will be structural change in the vessel wall, which will lead to peripheral vascular resistance, so hypertension. Now, which are the environmental factors that will lead to hypertension? Stress. Chronic stress will lead to catecholamine release and hypertension. Obesity, which will lead to increased lipid level in your blood, atherosclerosis development, and so you have a structural change in vessel wall, which will lead to hypertension. Smoking obviously have a many mechanism for Peripheral vascular resistance, so it can lead to hypertension. Lack of physical activity, important factor. If you doesn't, if you don't do the regular walking, jogging, swimming, if you have a reduced physical activity, then the blood flow to the organs will be hampered. You have a more peripheral vascular resistance that will lead to hypertension. But with physical activity, you can have a vasodilatation in your organs, and so it will reduce the blood pressure. Heavy sodium intake, very important factor for hypertension. We know that if you take a more sodium, you have a more blood volume and hypertension. All right. There are more than 60 genetic loci identified, which will lead to blood pressure elevation. These are the loci, right? It can affect at aldosterone metabolism, it can affect at your sodium reabsorption, or it can lead to smooth muscle cell growth. So genetic and environmental factor ultimately will lead to hypertension. What is the pathogenesis of renovascular hypertension? Inner renal artery stenosis or inner vasculitis or inner atherosclerosis of renal artery. So in such cases, because of stenosis of an artery, if the artery is narrow, if the blood flow to the kidney is hampered, you have a less glomerular blood flow. So you have a less blood flow in the afferent arterioles. So you have a more renin secretion. Because of more renin secretion, you have a more angiotensin 2 production, right? You have a more angiotensin 2 production, which will ultimately lead to aldosterone production, sodium and water reabsorption, increased blood volume, and high blood pressure, right? So, aldosterone will lead to vasoconstriction as well. Angiotensin 2 can have a direct vasoconstriction effect as well. So, there will be increased vascular resistance, which will also contribute to the hypertension. So, by vasoconstriction and by aldosterone production, you can have a hypertension whenever renal artery stenosis. So, that is the main pathogenesis behind the secondary hypertension. So, which are the consequences of hypertension if it is not treated? So, whenever the patient is having hypertension, it will lead to endothelial injury. So you will have a chronic inflammation. And because of chronic inflammation, ultimately there is a tunica intima thickening. There will be atherosclerosis development. And we know that if the vessels are constricted, atherosclerosis means luminal narrowing of artery by thickening. If your artery is thickened, the blood flow to the particular organ is affected because the lumen is narrowed. So if your coronary artery is having severe atherosclerosis, then blood flow to the heart is impaired. So you can have a ischemic heart disease, particularly angina or myocardial infarction. If your cerebral artery is affected, then you can have a stroke. You can have a less blood supply to the brain, so you can have a stroke. Intracranial hemorrhage because of vessel rupture can occur. And because of hypertension, the heart need to pump more, increase heart rate. So ultimately you can have a ventricular hypertrophy as well, right? So these are the main consequences: left ventricular hypertrophy, heart failure, heart attack, ischemic heart disease, brain stroke, right? Kidney failure, and organ damage, particularly retina damage, vision loss can occur because of retinal hemorrhage. So these are the consequences. The most important consequences is atherosclerosis, right, which ultimately lead to ischemic heart disease and brain stroke. So how atherosclerosis develop? How atheromatous plaque will develop because of hypertension? So whenever you are hypertension, you have this endothelial injury, right? So because of endothelial injury, you will have a chronic inflammation, and because of chronic inflammation, you have a chronic inflammatory cell in your vessel intima. Particularly, this is lymphocyte, and this one is a macrophage. So you will have a lymphocyte macrophage in your tunica intima because of chronic inflammation. And these macrophage are activated, which will ultimately lead to production of transforming growth factor alpha, platelet derived growth factor, epidermal growth factor. So this fibroblast growth factor. So this growth factor secretion will lead to excessive extracellular matrix production. So they will lead to more production of collagen, elastic fiber, and proteoglycans. This is known as an extracellular matrix. And we also know that chronic inflammation ends up with fibrosis. So you will have a more fibrosis, more collagen because of chronic inflammation. Because of chronic inflammation, you are having T lymphocyte and macrophage in your tunica intima. And here, because of growth factor secretion, the smooth muscle cell will also be recruited in a tunica intima. We know that artery is having three layers. This is tunica intima, this is tunica media, and below which you have a tunica adventitia. In atherosclerosis, you have an intima thickening because of chronic inflammation, because of smooth muscle recruitment, lipid deposition, and by fibrosis. Now, surprisingly, the smooth muscle cell here comes in a tunica intima from the media just because of release of growth factor from the macrophage. which will recruit the smooth muscle in an intima. And here you can see that smooth muscle as well as macrophage both will imbibe lipid within it, which is known as a foamy cells. And the lipid here is a LDL, particularly oxidized LDL. Now you have a question, why there is oxidized LDL? That is because of free radical production, because of endothelial injury, right? So that free radical will convert LDL into oxidized LDL, which will imbibe, which will consumed, because consumed by macrophage and smooth muscle cell, which is known as a foamy cell. You can see that here foamy cells are seen, right? In a histopathology section, it will look as a white vacuoles because the fat is lost during the histopathology processing. So you have a chronic inflammatory cells, smooth muscles, extracellular matrix, collagen, and the lipids, lipid within the cell as well as outside the cell as well. So these are the three main components of a atheromatous plaque: chronic inflammatory cells, smooth muscle, extracellular matrix, and lipid. These three together will form a atheromatous plaque. In an old stage, because of tissue damage, dystrophic calcification can be seen. So here you can see that because of all these three main components, the tunica intima is thickened, and that is known as a atherosclerosis. When you have atherosclerosis, this intimal thickening more than 75%, the lumen narrowing is more than 75%. Because of this patient can have a ischemic heart disease, heart attack, or patient can have a sudden cardiac death. So because of intima thickening, suppose the coronary artery is having atherosclerosis since a long time, especially if the atherosclerosis lead to luminal narrowing, the arterial lumen narrowing more than 75%, then what will happen? Ultimately, there will be less blood flow to the heart. If you have a coronary artery atherosclerosis, then there will be less blood flow to the heart. So your cardiac smooth muscle will get necrose because of less blood flow. We know that there will be irreversible cell injury in the form of necrosis. So here the necrosis will be coagulative necrosis. In a solid organ, we know that uh, there is a more chance of development of coagulative necrosis. So because of ischemia to the heart, there will be coagulative necrosis. That is known as a myocardial infarction. Infarction means ischemic coagulative necrosis, and here the necrosis is ultimately because of atherosclerosis, right? Because of less blood supply. So hypertension ultimately will lead to atherosclerosis and myocardial infarction. In brain, it will lead to cerebral infarction, brain stroke, which is known as a brain stroke. And we know that in coagulative necrosis, we have a neutrophil recruitment. Initially, we have a neutrophil recruitment up to 48 hours. Because in necrosis, the main inflammatory cell is neutrophils. There will be membrane damage. And here we can say that this is a coagulative necrosis because the nucleus is lost and it looks like a pink granular. The hallmark of coagulative necrosis is outline of the cell is maintained. There will be loss of nucleus and it is a pink granular. You can see that the nucleus is lost here, right? So it's a coagulative necrosis, right? All right. So it's a irreversible cell injury. Because of hypertension, the compensatory because of hypertension, there could be chances of left ventricular failure ultimately, because the heart is also having the capacity. If you have a long standing hypertension, then particularly your left ventricle can get failed, and because of that, compensatory mechanism can get activated. Why compensatory mechanism is activated? Because of left ventricular failure, kidney will get a less blood flow, because the cardiac output will ultimately decrease because of ventricular heart failure. So because of that, if the kidney is getting less blood flow, there is activation of renin-angiotensin system, which will lead to sodium water retention. We know the mechanism how, right? So because of sodium and water retention, there could be, ultimately further stress on myocardium, which will aggravate the heart failure because of increased blood volume. Because of activation of norepinephrine catecholamine release, there will be tachycardia and ultimately congestive heart failure. As a compensatory mechanism, myocardial contractility also can be increased, which will lead to increased cardiac output, cell stretching, and compensatory hypertrophy and dilatation of heart can occur, which is known as a dilated cardiomyopathy. Here you can see that in left ventricular hypertrophy, the muscles have enlarged in size as well as there is a nuclear enlargement. You can see that hypertrophied myocardial fiber. Hypertrophy means increase cell size. So here the smooth muscle cell size is increased as well as nuclear size is increased, which is known as a boxcar nucleus. So this is a case of left ventricular hypertrophy. So we can have a conclusion that if you have uncontrolled hypertension, then you can have a chances of atherosclerosis, you can have a chances of dilated cardiomyopathy, left ventricular hypertrophy, Because of atherosclerosis, you can have a ischemic heart disease, myocardial infarction, brain stroke, and importantly, if you have uncontrolled hypertension, particularly accelerated malignant hypertension, which is defined by systolic pressure more than 200 and diastolic more than 120, then you can have a renal failure or retinal hemorrhage as well, papilloedema, right? So because of retina involvement, patient can have a vision loss as well. So these all are the complication of the large and medium sized vessel. But what if your small vessel is involved by hypertension? Small vessel means arterial and venule, which is also having endothelium. So if they are damaged, the protein will get exudate, and because of that, you can have a arteriosclerosis. Arteriosclerosis means thickening of small vessels. So if you have a chronic benign hypertension, then you can develop hyaline arteriosclerosis. And if a patient is having malignant hypertension, means more than 180, 200 systolic and more than 100, 110 diastolic, then it is malignant hypertension. Because of that, hyperplastic arteriosclerosis can develop. So there are two spectrum of small vessel disease, particularly morphology, right? Morphology means gross and microscopic changes. So there are two spectrum of morphology of small vessel involvement by hypertension. In a benign case, hyaline arteriosclerosis. In malignant case, it is hyperplastic arteriosclerosis. So what is the pathogenesis of hyaline arteriosclerosis? Because of chronic hypertension, you will have a chronic hemodynamic stress, which will lead to endothelial blood vessel damage. Because of that, there will be leakage of protein into the vessel wall from the plasma. We know that in a lumen, in a vessel, in the middle, there is a plasma flow. So if you have endothelial damage, the plasma will leak, protein will leak into the vessel wall. And because of growth factor release, you have a chances of increased extracellular matrix synthesis by smooth muscle cells. Extracellular matrix means you have a more proteoglycans, you have a more collagen deposition. And because of collagen deposition, there will be homogeneous pink hyaline material deposition, pink colored thickening of the vessel wall, which will ultimately lead to narrowing of the lumen. That is known as a hyalinization of the arteriole. And that's why the name given is hyaline arteriosclerosis. So hyaline arteriosclerosis means because of increased extracellular matrix production, homogeneous pink hyaline material deposition and narrowing of the lumen, that is known as a hyaline arteriosclerosis. So this is the case of hyaline arteriosclerosis, pink hyaline material deposition. And ultimately, because of collagen deposition, fibrosis, because of chronic inflammation in a kidney, your glomerulus will be sclerosed, right? And so ultimately, the kidney size will be reduced. And you can see a multiple depressed scar over the kidney. These are the scar. The scar is because of fibrosis. We know that whenever we have an injury, any type of wound, it healed by a scar. So we have a lots of scar over the kidney, and the size of kidney is reduced in a benign hypertension. So the small vessel change are mainly seen in a kidney. In a benign hypertension, we have a hyaline arteriosclerosis. But if you have a malignant hypertension, then there is a more endothelial damage, so more increased permeability for the plasma protein and fibrinogen. There is a more platelet deposition. There is a more growth factors, and because of that, there will be proliferation of smooth muscles and an excessive collagen deposition, and you will have a fibrinoid type of necrosis. This type of necrosis is known as a fibrinoid necrosis because you have a fibrin-like material deposition and you have a damaged cells, irreversible injured cell. So that necrosis is known as a fibrinoid type of necrosis. It looks dark pink color on histopathology section, which is stained by H stain, and the proliferation will look like a onion skin, and that's why it is given the name hyperplastic arteriolitis. And because of that, there is a luminal narrowing, there is a further ischemia to the kidney, and we know that when the ischemia to the kidney is aggravated, there is a activation of renin-angiotensin system, which will ultimately increases your blood pressure. So this is a vicious cycle which is ongoing in case of an hypertension, right? So this is the hyperplastic arteriosclerosis. There is a smooth muscle growth, there is a onion skin proliferation in a vessel wall, and here you can see a fibrinoid type of necrosis that is known as a necrotizing arteriolitis. It looks like an onion skin, right? That's why the name given is onion skin proliferation. We know that there are many varieties of necrosis: coagulative, liquefactive, caseous, fatty necrosis, and fibrinoid necrosis, right? So here you will have a fibrinoid type of necrosis in a malignant hypertension, which is known as a hyperplastic arteriosclerosis, right? This morphology is known by the name hyperplastic arteriosclerosis. And in a hyperplastic arteriosclerosis, you have a very high blood pressure, because of that vessel can be ruptured and you can have a petechial hemorrhage over the kidney, which is known by the name flea bitten type of kidney. That's because of petechial hemorrhage on the cortex of kidney. This is also seen in a post-streptococcal glomerulonephritis. So in a benign hypertension, the morphology is hyaline arteriosclerosis, right? In a benign hypertension, morphology means gross and microscopic changes. So in a benign hypertension, gross morphology is small contracted kidney. In a microscopic morphology, you can see a hyalinized thickening of vessel wall, which is known as a hyaline arteriosclerosis. In an uncontrolled malignant hypertension, you can have a fibrinoid necrosis in a vessel wall and it looks like an onion skin proliferation, which is known as a hyperplastic arteriosclerosis. And grossly, you will have a petechial hemorrhage. So that is the morphology of small vessel disease in case of an hypertension. So hypertension can affect your large and medium vessel, in which you will have a atherosclerosis because of that ischemic heart disease, brain stroke, left ventricular hypertrophy, like that of complication, retinal hemorrhage. But at the another spectrum, hypertension can affect a small vessel, particularly kidney. So you can have a hyaline arteriosclerosis or hyperplastic arteriosclerosis depending upon your blood pressure value. So small vessel disease can be developed as well because of hypertension. This is the morphology of small vessel disease, hyaline arteriosclerosis and hyperplastic arteriosclerosis. In a large vessel disease by hypertension, you need to write down atherosclerosis. So this is all at the nutshell about the hypertension in our body. These are the references for my lecture. So thank you very much. Hope your fundamentals regarding the hypertension might be cleared, particularly the morphology of hypertension and pathogenesis of hypertension might be uh, cleared by at the end of this lecture. I have tried my best to explain the pathogenesis and morphology of hypertension. However, we can have a more session on hypertension as well. But as of now, this is all about the hypertension-induced organ damage and morphology of hypertension in a large and medium-sized vessel and small vessel disease. Thank you very much, and we will be right back with a new video. Till then, take care and bye bye. Hope you have enjoyed. Thank you very much.